to the Way to Be podcast. This is where we chat about all things awesome in health professions, partnerships, and practice today. I'm Rachel Glade, and
I'm Elizabeth Rosenzweig.
And we both have experience working with children with hearing loss, and we're going to be your hosts for today. Today, we are talking about the past, present, and future of auditory verbal therapy, and we could not be more thrilled with our guests today. So we are welcoming Dr. Jane Maydell and Dr. Carol Flexer to chat with us today. So thank you for joining us today. We are thrilled.
Thank you so much for having us.
Thank you.
Yeah. All right, so Elizabeth is going to toss out our first question here. So Elizabeth, what do we have for them?
Sure. So would you each please share with our listeners, how did you come to this field?
I had a cousin with a hearing loss when I was growing up, which he got from rubella, which fortunately we don't have anymore in this country, although we still have it in other places. And I was looking for something to do. Old enough so that I grew up at a time when I didn't think I could be a physician. And so I wanted to do something where in healthcare where I could do independent practice. I didn't want to I knew I couldn't be a nurse. I don't take direction well. And I went to, I was a volunteer at the New York League for the Hard of Hearing, where my cousin went for therapy on Saturday mornings. And I decided, I really like this. I think this is what I'm going to do.
So my turn. I just fell into it. I didn't know any young person growing up who had a hearing loss. I did start out in nursing at the University of Colorado. And like Jane, I played with, do I want to be a physician? But being at that point in time, it didn't seem like a sensible thing to do. So I played around with majors and ended up in broadcast journalism. Right? That makes sense. Nursing, broadcast journalism. Not at all. Well, at that time, you couldn't get an actual degree in broadcast journalism undergraduate. It had to be a general speech degree. So to do that, I had to take some courses in speech language pathology that I had heard about. And I really liked the courses. There was about 2 weeks in one of those courses about audiology. Never heard of it. Never heard of it. Fell completely in love. Just fell in love with it. And I just never looked back. And I've just kept that love in my heart for all of these many years.
I agree. Yeah.
So in thinking about kind of how you got to your profession, also that gave you some time to kind of reflect maybe on how our profession has progressed, like past to present. So I wonder if maybe if you two were to maybe provide us kind of in your mind, what's the highlight reel of kind of past to present, maybe for the field of like auditory verbal therapy or maybe even pediatric audiology? What are your thoughts? What are the high points?
Carol, you go first this time.
Well, what I'm thinking of is the high points for all of our fields, and that is the advancement of technology, that we can screen hearing at birth. You know, I got my master's at the University of Denver, and I got to do externships with Doreen Pollack and with Marion Downs and Jerry Northern. So I just had access to these amazing women. Well, not Jerry, but the other two amazing women, and just saw the work they could do. But at that time, I was working with Marion. I did one of the things where she had the Warbalette for newborn hearing screening. It was like this big thing, and you put it over the baby's head, and it went. And if the baby moved, well, their hearing was okay. Everyone knew that didn't mean their hearing was fine, but they at least heard something. Well, going from there to ABR and otoacoustic emissions. Phenomenal that we can identify babies at birth, and then we can do something about it. We can get to their auditory brain through digital hearing aids, cochlear implants. Amazing progress.
Yeah, I started at Emerson College, and David Luderman, who is the god of counseling, was the head of the program. And wow. So I learned from David. And then when he started the deaf nursery, I was the first audiologist. I had gotten my master's degree. He invited me back. And he was amazing. And I remember, I've told, I think at least Elizabeth and Carol have heard this story, that one day I went into him and I said, this child's not testable. And he said, what you mean is you don't know how to test this child. And it was like an amazing light went off in my head. And I thought, that's exactly right. It can never be the child's fault. It's a child. We have to figure out how to solve all the problems. And then after I worked with David, I worked at the New York League for the Hard of Hearing after I got my PhD. And it was, Dorothy Noto Lewis was one of those first auditory verbal therapists. And Bibi was very close by, so we worked with her also. And Dorothy she did not believe that you couldn't teach a child to listen. Mm-hmm. And so I believed you could teach any child to listen. And that was before cochlear implants. And I just figured out ways to evaluate infants. I figured out that you could look at sucking and determine what a baby was hearing so that we would know what to do about technology and to monitor the technology. And I got to see a lot of infants because that was a very big program. And I would see all the children, the younger siblings of everybody who is identified with a hearing loss. And when I went to the New York League, Dorothy was about to retire, and they had originally had adult services and children's services. And now they were dividing into audiology or speech. And because I was licensed and certified in both, I got to pick. Mm. And it was a very hard choice for me because I wanted to continue to do therapy. And so I did. I ran the audiology program, but I did do therapy. And I just watched everything progress. And I remember when cochlear implants came out, and I thought, this will never work.
I thought so too. I thought, are they nuts? What,
That's what I said. I said, this is not going to work. And Ron Hoffman, who was the surgeon I worked with, said, well, do you think we could try it? I said, all right, we'll try it. And of course, you don't have to do too many of them to become convinced that this is the miracle of all miracles when it comes to hearing. And so it was just, I've watched things move along. I can tell you that the thing that's disappointed me, I was very upset when the audiologists separated out of ASHA. And I remember that meeting it was an ASHA meeting, and a bunch of men with one woman stood up and said, we're going to move out of ASHA. And I stood up and I said, if we do that, audiologists will lose rehab. And we really can't do that if we're working with children. Actually, we can't do it if we're working with adults either, but, and nobody listened to me. They thought I was overstating the case. But if you look at the AAA program, you see that there's almost no rehab. It's a lot of commercial stuff. And so I think that we've lost something in this process of growing that maybe it would be better if we hadn't.
Mm-hmm. It's fascinating to hear both of your stories and think about kind of the lineage of our profession, because I think about the could not test versus you can't test that David said to you, Jane, and I've heard you say that story, and I tell it to my students every year, and I say, Jane Mydell said. And I think so many of those things that come from both of you are things that I say, I'm sure Rachel says, and the way that our field moves forward. I'm wondering if you think about the next 10 years, what do you see on the horizon? Where do you see the field going?
Very concerned about the inability to provide auditory verbal therapy and other auditory rehab that families need. There aren't enough therapists. I think that the capital D deaf community, the signing deaf community, is very strong and pushing very hard to have sign language be what families hear about first when a child is identified with hearing loss. And I'm very concerned about that because I think it's going to make it very hard for families of newly identified kids to move along and learn how help their children listen and talk.
Yeah, I completely agree with that because of what we've learned about auditory neurophysiology. We know that the brain cannot wait to receive auditory enrichment. And what happens when parents don't get that information right away is there's delay. So all the advantage that we have by doing newborn hearing screening and knowing this doorway is a problem and we can reach the brain, that advantage is lost if the parent is not encouraged, if we don't approach this getting sound of the brain with hair on fire. And then we've lost the amazing advantage. And then we've thrown this child into auditory neural deprivation, which is very difficult to untangle. So the good news is we know more about auditory neurodevelopment. The bad news is we aren't capitalizing on what we know in a way that we can make a profound difference in the development of children. And the fact that we know that 95+% of children with hearing loss are born to hearing parents, and they know how to talk. And if they aren't coached and guided about managing their child's doorway, enriching their child's brain, doing what they know how to do to teach language to their children, then we aren't doing a service to this generation of children that we should be doing.
I agree.
So I wonder, as a follow-up question to that, what advice might you have for a family that's kind of on the fence of thinking about, maybe sign language? I hate to say like sign language versus spoken language, because is there a world?
That's what it is. That's exactly what it is, Rachel. It's sign language versus spoken language.
Yeah. Is there a world where there is an opportunity to develop those listening skills while also learning signs? So maybe like a total communication approach for this family that maybe is on the fence, or what are your thoughts on that?
Well, I would want to know, first of all, why they're on the fence. If they're a signing family, then of course they're going to sign. What's the family's home language? Because that's the child's culture, is the family's language and who the family is. So, see, one of the big issues is discretionary time. How much time does the family have to devote to is what's going to be their child's development? Now, every choice takes time. If you're choosing listening and spoken language, there needs to be time involved in managing the technology. That wear time is critical, 10 to 12 hours a day. Language enrichment is critical. Now, you're also going to devote that same amount of time to learning another language, which is sign language, and enriching that child in this language you don't actually know. We know that learning is time on task based. The more time you spend on a task, the more likely you are to learn that task and to get the outcome that task allows. So what is it the parent wants? What's their desired outcome? And what's it going to take to get there? What does it take from the parent? And how can we support them in that? And attaining that outcome? I think it's pretty simple. If the parent isn't focused, you get mission drift. If you want listening and spoken language and you're not focused on doing what it takes, which is a system approach, then you're not likely to get the outcome, and we're wasting valuable brain development time and knowledge development time.
I completely agree. And what I say to families is your child can learn sign language in a few years. When that child already has spoken language, this child can choose to learn sign language. And I've had some of my kids who, when they got to college and did that junior year abroad, decided to spend that semester at Gallaudet because they wanted to learn about that community. By then, these kids are completely fluent in spoken language. And actually, by the time they're in junior high, they can learn sign language. But they're not going to learn spoken language well unless they learn it at the beginning. Mm-hmm. You can learn sign language later. You cannot learn spoken language later. So if you look at children who didn't get spoken language early, you hear in their voices, you hear in their language that they don't have typical developing language. And so those children, we're not going to make it up later. So first you have to learn spoken language. Then we're not saying you should never learn sign language. We're saying it's not something to do in the beginning. You can do sign language later on.
Yeah, because again, if you want listening and spoken language, your time on task, your energy, your discretionary time with your children needs to be focused on that particular task and that particular outcome. If you dilute that language energy, it's going to make a difference in that what that child knows, their knowledge development, their cognition. This, but you bring up a good point, because it meaning how the parent communicates with the child. It's not a surface conversation. It's a conversation that has layers to it, and that often requires multiple professionals having multiple conversations. It's not a means of coercing the parent. We say it's parent choice, but they need to know what they're choosing. They need to know what it takes for each of the choices, and what that choice demands of the family, requires of the family. Demand sounds punitive. What requires of the family, and what is it the family is able and willing to do. So there's like layers of this conversation. And I think, because just on the surface, if someone says, what can it hurt to sign? Do the signs. It hurts.
Use baby signs.
Yeah, right. And the fact of the matter is, when we talk, we do gesture. We do gesture. That's just part of communicating and talking. And baby signs is not sign language. It's just a type of gestures, of more focused gestures. It's not really a language. But then that's another conversation to have. So, yeah, it's.
I think if you look at the literacy levels of children who graduate from high schools for the deaf, where they have not had auditory access, they are around fourth grade. That is not supportable in the United States at this time. We don't have enough of the kind of jobs that don't require language anymore. And children.
Go ahead. Sorry.
I remember being at an EDI conference. Carol had given a talk, and she and I were sitting there while a lot of people were yelling at us about our viewpoint afterwards. And there was this mother who said to me, my son graduated from NTID with straight A's. He's got a degree in engineering, and he only signs, and he can't find a job. And it was as if that was my fault, because I was saying you should be teaching your child to speak. And I felt terrible for this mom and for this kid, because here was a really obviously smart kid who did well, but who couldn't communicate in the work world. And that's what happens if you can't speak the language of the culture.
And so that was advice for parents. If we shift now, thinking about people getting into the professions, what advice would you have for a student or a new professional, a young professional, to succeed in this field?
Well, the first thing I would say is spend a little time watching people doing the work. And that will help you figure out if this is the work you want to do, because you can't tell that without being in a clinic. If you are interested in children, I really believe you will be the best clinician possible if you are both an audiologist and a speech-language pathologist. If you have both of those skills, I think you can be the best clinician you can be, because I use a lot of hats when I see a child. I want to know how they're hearing, and I use their speech production to tell me which sounds they're not hearing, and my knowledge of speech acoustics to know how to look at how I can modify their technology so they'll hear better. And that's for hearing aids and for cochlear implants. And each ear separately and both ears together, and in noise and not in noise, and at normal conversation and soft conversation. It's the combination of all of the things I know from both areas that help me to be the clinician I am.
Yep, you're right. Unfortunately, in this day and age, it's almost impossible to have your degrees and your credentials in both because they did separate audiology and speech pathology. You have the AUD degree, audiology, you have speech pathology, and it would take a very determined person to be able to get credentialed and trained in both areas. I think if your question was how to be an auditory verbal therapist, Elizabeth, was that it? That
Sure.
probably because birth to three is so critical, that's usually done by speech language pathologists. Probably, and as Jane said, you definitely want to observe and view different clinicians at work, different therapists. But it would probably be starting at speech language pathology, but getting as many audiology courses as you possibly can, because you need, even if you don't actually fit hearing aids, you certainly do need to understand how hearing aids and implants work and how they can access different speech sounds, speech acoustics. So it does, and getting the LISL credential really helps because getting that credential requires knowledge in all of these areas in a way that a person isn't going to be able to probably network within a university system.
Yeah, and for those that may not know, if you're interested in that, the LISL certification that was referenced, if you go to the AG Bell website, agbell.org, there's plenty of information there on the steps that are needed for that. So my follow-up question, because we've talked a little bit about, advice for parents and then advice for maybe rising professionals. What tips would you have for current professionals or maybe even more seasoned professionals in working with families? Because I know you guys do a lot of, mentoring and counseling and working with families. So what might your top tips be for working with families for current professionals?
Okay, I have one thing for sure, and that has to be with information professionals have. There was just a recent article out just this year that had to do with literacy, health literacy, and hearing loss history. And I'd have to look up the authors. But the interesting thing is, the study was done, this was mothers who had very high health literacy. They have children who've had hearing loss. They've had these children for over 3 years, and their literacy about hearing loss was very low. So here's the thing. I think we need professionals to understand that families don't come into this knowing and understanding about hearing loss. And it's very critical to provide information about hearing loss, about auditory capacity, about neurophysiology. Of course, we tailor it to the parent, but I think we may overestimate how much parents really know and understand about their child's hearing, their brain development, and their use of technology. At least that's what I got from this study. And I was actually quite surprised.
I agree with that. I think I think that we need to, one of the things that Carol and I talk about all the time is that parents need to hear the same messages over and over again.
Yes.
You don't always get it the first time. Just think about any health crisis you have had or a family member has had. You don't always get the information the first time. Sometimes it's because the provider isn't giving it to you, and sometimes it's because we don't have the energy to ask. If you tell a family they have a child with a hearing loss, they're overwhelmed and they don't know where to begin. I believe that virtually every child can learn to listen and talk.
I agree.
So I'm comfortable saying that to families. Mm-hmm. And I tell them what they're going to have to do to make that possible. And then I do talk about what the options are, and I talk about why this is the option I support. It's very important to listen to families. It's not just all right to, it's not just all right to tell them. You have to listen to them. You have to hear what they have to say. You have to see what's going on in their minds. I also invite grandparents to come. I had an experience in my family where somebody was having a serious medical issue, and the physician said, "Bring your whole support group so I can answer all the questions at once." That was an amazing thing to me. And then I started saying that. Bring your siblings, bring the grandparents. Let me talk to all of them, because grandparents, their attitude is, "It'll be all right. He's adorable."
Yeah.
My son was born with
He'll grow out of it. He'll grow out of it.
My mother said, "He's gorgeous. Don't worry." And I looked at her and I thought, really? But, she was trying to make me feel better. It didn't help me. And that's what happens. But I think that if we can get everybody in the family to buy in, then we have a better chance of being successful. How many times have you had a family come and say, they tell you that grandparents take care of the kids when they're at work, and the grandparents don't want to keep the technology on? They may keep it on when you bring the child to them, but once the child takes a nap, it doesn't go back on. Or once the child has a bath, it doesn't go back on. That's because we have not explained to the grandparents what the point of the technology is.
Which leads us to the brain conversation that we need to have ongoingly, that when people get that what we're doing with the technology is developing, nourishing, growing their child's brain for thinking, for learning, for making friends, who would not want to keep the technology on? So that's the brain, that everything is really that we're doing is about brain development and integrating that auditory neural system. And that's a conversation we have to keep having over and over again as well. And when the technology isn't kept on, then I realize I'm missing something here. I haven't explained this. Of course, I ask, what's the problem? What is going through your head, parent? Why aren't you putting this on? Or why isn't how can I help you with it? But what I ultimately understand is they don't get it's about their brain. And by the way, I've never met a single parent ever who didn't know their child had a brain. Really. Never. I've never had someone say, "What? A what? A what? He has a what?" No, I've never had anyone say that. So when you mention a brain, and also there's so much talk about the brain-based learning, brain-based literacy. There's so much brain-based emotional control. So when we talk about the brain, I think that resonates more now than ever before, when that is kind of a general conversation.
I agree.
What a strong way to end before our rapid fire round. It is all about the brain, right? If you're taking nothing away from all of this wisdom, at least take that away. All right. So now we come to our favorite part of the interview, which is our rapid fire round. So I am going to share my screen where I have a 90-second timer, and Rachel and I are going to fire off questions. You are welcome to say pass if you can't think of something or you don't want to answer it. And who wants to go first?
Carol does.
Oh,
what a friend. What a friend.
Okay.
All right. 90 seconds on the clock. Rachel, you'll ask the first question. Here we go.
Okay. Coffee, tea, or soda?
Coffee.
What inspires you to get out of bed in the morning?
Having something to do that is worthwhile.
Awesome. Cats or dogs?
Cats.
What's your favorite color?
Red.
Morning person or night owl?
Morning.
What is your go-to karaoke song?
Oh, it's that old time rock and roll.
All right. Netflix or YouTube?
Netflix.
Netflix.
What? If you could speak any language fluently, what would it be?
Hebrew.
Fiction or nonfiction?
Fiction.
If you could have any superpower, what would it be?
Oh, flying.
City life or country?
City.
What is the most important lesson you've learned in life so far?
Oh, to be kind, to not judge, to be helpful. How can I help?
Sunrise or sunset?
Sunset.
What is the weirdest food combination you enjoy?
Oh, golly, pass. I'd have to think too long
That's a hard
about
one.
that. Yeah.
All right. Windows or Mac?
Oh, Windows.
What is your favorite recipe to make and why?
I don't cook.
I love it. Okay. You made it through the gauntlet. Rachel, you asked the first question. Ready, set, go.
All right. So what is your spirit animal?
Pass.
The strangest thing you've ever found in your pocket, purse, or wallet?
Really old candy.
So what is your favorite era of movies?
The 40s and 50s.
What is your secret weapon for surviving long meetings?
Knitting.
Yeah, I knew that.
So if your office were to have a mascot, what might it be?
Big Bird.
What is your favorite vacation destination?
A beach, anywhere. Summer, warm weather, and a beach.
So same question as before. So morning person or night owl?
Morning.
What apps on your phone are integral for your daily life?
Texting.
So what's your favorite recipe to make?
I do a lot of cooking and baking. I don't know if I have a favorite recipe. I made enchiladas a couple of days ago for my granddaughter. She was here visiting. That was fun, except it takes a long time.
What is a valuable lesson you have learned from failure?
David Ludeman once said to me, you don't know how to test the baby.
There you go. See, it really brought it home for us. Full circle.
Yeah, look at that. Well,
Yeah.
awesome. Well, thank you both so much for joining us today. I guess there's really only one thing left to say. Way to be, Dr. Maydell, and way to be, Dr. Flexer. So perhaps someone in our audience, is thinking about what we've talked about today, and perhaps they're thinking about audiology or speech language pathology or auditory verbal therapy, so that might be a way to be for them, maybe in the future. So we are wishing you all the absolute best, and we're looking forward to future conversations. So thank you again so much for joining us, and we'll see you next time.
Yes, thank you for having us. This is really fun. Thank you.